does prolongation of pregnancy by 1 week improve mortality or morbidity because delivery is 1 week later? I think there is clear evidence that it is, especially when we are talking of gestations which are more than 29 to 30 weeks. So it's worthwhile giving tocolysis, but we must remember that tocolysis works only for a short period of time. So what is the evidence for prevention of preterm labor? Really, we need to watch the space, but increasingly, I think we will be relying on history and on, to a larger extent, on cervical length, and look for other biochemical markers which may be available to us. No talk on prevention of preterm labor can be done without talking about progesterone. Again, when we're looking at the use of progesterone on preterm labor, we need to know which is the subgroup of women that we are wanting to give that progesterone to. So are we looking at the women who are at high risk, who have already had a preterm birth and a short cervix? Are we looking at symptomatic women who are coming in with contraction and cramping in this pregnancy, or women who are asymptomatic with short cervix, or women with low risk, multiple pregnancy with no other additional risk factors? Depending on the subgroup, the evidence on progesterone is varying. So this is a result of a systematic review by Dodd. They've looked at about 2,400 women, and this is the gist of their conclusions, that women with a history of spontaneous preterm birth, both vaginal progesterone and 17-hydroxyprogesterone intramuscular, results in a significant reduction in preterm birth before 34 weeks. If a woman has a short cervix identified on mid-trimester ultrasound, then again vaginal progesterone is associated with the reduction in preterm birth before 34 weeks. But in women with a multiple pregnancy without any other additional risk factors, there is no significant difference in the rate of preterm birth by giving her progesterone. Now, Cochrane again says that there is a statistically significant decrease in preterm births in singleton pregnancies with a previous history of preterm birth or a shortened cervix. Now, the FMF study on the short cervix study, their cutoff, of course, was a cervical length of 15 millimeters, and there again, there was a 44% reduction in preterm births. And in multiple pregnancy, like I said before, there is no change in preterm births, and the jury is still out on the benefit of progesterone in multiple pregnancies when there is a short cervix. Progesterone is not an acute tocolytic, so you don't give it in somebody who comes contracting in preterm labor, and the role of prolonging pregnancy with progesterone after we give them tocolysis is still not clear. Indeed, if we look for evidence on maintenance tocolytic therapy in any tocolysis, there is very little data about the fact that it is of value. Before I finish, I'd just like to say a little bit about the cervical pessary, because there is a lot of research that is, or studies that are happening on it. It was initially reported in 2003, and the Cochrane review on the cervical pessary is that while there is no randomized control trial yet, evidence from non-randomized trials show benefit, and there are 3 ongoing studies whose results are awaited. The pessary is called an Arabin pessary. This is how it looks like. It's a flexible ring-like silicone pessary, comes in different sizes, and it's inserted with its curvature upwards so that the larger diameter supports the pelvic floor and the smaller diameter encompasses the cervix. And the initial preliminary study seems to show a significant reduction, probably works very much like a cervical stitch without putting a woman through the surgical process. So to sum up, what do we do and what do we not do? The role of routine cervical length screening in all women across the board is not yet established. But in high-risk women, it definitely does have a role to play, and we can use cervical length to guide management in threatened preterm labor. Fetal fibronectin again has a very high negative predictive value, but we don't have it for our practice in India. The biggest, most important thing in women who have previous preterm labor is for us to take a detailed history to try and understand what was operational at that point in time, and not club every woman who has had a preterm birth at say 22 to 28 weeks under the same group, because different factors may be operational in different women, and we need to try and identify that fact to get optimal outcome in the next pregnancy. Infection screen is of value in women who've had a previous preterm birth, and like I said, progesterone and cerclage depends on the subgroup. There is definitely a subgroup who will benefit, but it is not something that we should give all women with preterm labor. And tocolysis, obviously there's appropriate indicated use, especially to gain time to give steroids. So if I've added to your confusion, I think I've served my purpose well. Thank you very much.